Myopia is no longer a refractive error. It is the fastest growing eye health challenge of our time. While we have long recognized diabetic retinopathy clinics and glaucoma services as essential components of eye care delivery, same level of systematic focus on myopia is still emerging. This IC aims to fill this gap. Myself is Dr. Anila Josh from Srinetra Eye Care. I'm a pediatric ophthalmologist there. My topic is myopia mission is changing its trajectory and why every ophthalmic practice needs myopia clinic. Everyone is saying that myopia is going to be a pandemic, and we will realize the real impact of this saying only when we compare this with the prevalence of diabetes. You can see that 50% of the world's population is going to be affected by myopia by 2050. Myopia already affects, this is a graph showing the comparison of global prevalence of myopia versus diabetes. And myopia already affects more people than diabetes, as global prevalence of diabetes is about 540 million adults and global myopia prevalence is about 2.6 billion people. And by 2050, myopia may affect 5 millions of people. That is, half of the humanity will be affected by 2050. And the speed of increase is far greater than that of diabetes. While diabetes has strong awareness for blindness, myopia does not, despite similar or even higher risk volumes. This is a graph showing distribution of people having myopia across age groups in 2000 and 2050. More children with low vision today means more adults with disability tomorrow. Myopia has impact on both individuals and society. The social effects being educational challenges it provides, psychological impact. Myopia also contributes to greater psychological stress and anxiety in adolescents compared to those without vision defects. And there is limited participation in sports, especially those requiring clear distant vision. And it also impacts the productivity. And also there is social isolation and stigma associated with it. The economic impacts including the productivity impact, because people having vision problems can affect work productivity, especially in jobs that require prolonged use of screens or detailed visual tasks. Uncorrected vision issues or simply having an incorrect prescription may lead to errors and decreased work efficiency. And projecting this onto a wider scale, a recent study showed Southeast Asia had the greatest potential decrease in global economic productivity due to visual impairment resulting from untreated myopia, and the cost of that burden far exceeds the cost of myopia correction. And also, there is increased demand for vision correction products. And also, axial myopia has its own complications like cataract, glaucoma, retinal tears and detachment, macular scar, posterior staphyloma, CNVM, etc. Myopia management is the myopia management is more about treating myopia than correcting myopia. We all know that. So here comes the importance of myopia clinic, which provides customized care like diabetic clinics. Myopia clinic provides early detection, behavioral and lifestyle interventions, parent and patient education, structured monitoring, and evidence-based treatment. So the prevention is mainly by increasing the awareness, providing risk factor modification, and encouraging the outdoor play. Outdoor play should be between dawn and dusk, and it should be at least more than 2 hours. And it is found that the time spent outdoors causes less myopic refraction regardless of the activity performed, even if it is reading or sports. So it reduces the risk of onset of myopia by 50%. So preventing the onset is by identifying a pre-myopic child, that is by identifying childs with low hyperopia, with family history, less outdoor time, increased near work, and kids with binocular vision disorders like accommodative lag and high AC by A ratio. And early detection. When is the best time to start myopia management? It is at the time of onset. Why? Because in axial myopia, there is no safe level of myopia. Every diopter matters because axial length elongation has its own complications. This is the percentage of patients with high myopia in adulthood. So it is found that we can see that the risk of developing high myopia is greater than 50% for those with myopia onset at 7 or 8 years of age. And please consider the fact that we are now seeing myopia onset at the age of 3 or 4 years. So myopia management has changed its trajectory. In the earlier days, it was only giving spectacles. And now it has changed to prescribing defocus lenses, pharmacological management, and contact lenses. We all know the factors contributing to myopia. So I'm skipping that. And we all know about the factors contributing to myopia progression also. So the myopia progression has changed from simple cycloplegic refraction alone to peripheral refraction, measuring axial length, AL by CR ratio, choroidal thickness, and optical biometers are available, which measure all these parameters like axial length, corneal thickness, AL upon CR ratio, spherical equivalent, etc. And also predicting softwares like BHVA and LVPA myopia calculator is available, which help in knowing if this patient will progress or not, and which will provide a graphical map of progression. So the evolution of myopia management has came a long way from prescribing normal glasses to helping in providing environmental and lifestyle modifications. Initially, we have tried bifocals and progressive glasses, but now we have evolved. Major jump in management came with the introduction of the concept of peripheral defocus. So the myopia control now includes low-dose atropine, peripheral defocus spectacle lenses, peripheral defocus contact lenses, and orthokeratology. Also, red light therapy and contrast lenses have also gained importance. In all our enthusiasm to treat myopia, we should also keep in mind that pseudomyopes also do exist, and anxiety and stress being the common causes of pseudomyopes. A myopia clinic enhances clinical outcome by providing standardized protocols, evidence-based treatment. We can measure objective tools like axial length, corneal topo, AL upon CR ratio, etc. It provides consistent review schedules and better documentation of progress. And we have the ability to measure treatment effectiveness also. Coming to the future of myopia clinics, a lot of researches are going on this field, and myopia clinics are going to change a lot. AI-driven risk screening tools and automated alerts for fast progressors are going to come up, and a lot of biomarkers are going to be discovered, like tear film inflammatory markers and choroidal thickness nowadays. Axial length and peripheral refraction school screening will become the norm, and smart lenses that adjust peripheral defocus dynamically is going to come up, and atropine microdose dispensers, smart delivery systems, or sustained release implants like we do in retina will come up, and overnight lenses requiring fewer hours for ortho-K is going to come up, and smartphone tracking apps will be there for home monitoring. And also genetic risk profiling calculators, prenatal testing, and embryo treatment is going to come up. So AI plus personalized care is going to be the future standard of myopia management. Thank you. I invite Dr. Rashmi Bhaskar, who is a senior pediatric ophthalmologist from Chaitanya Trivandrum, to enlighten us on the infrastructure and workflow of myopia clinic.
Good afternoon. My topic is setting the foundation, infrastructure and workflow for myopia clinic. So, Dr. Anila has given a detail regarding why you need a myopia clinic. If myopia children are forming a part of your major clinical practice, it is better you have a specialty practice and a clinic allotted for that. The need for it is for the prevention, early detection and management of myopia progression. Regarding it is better, you need a separate room, or you can take it as a part of your clinic, and it should be near your consultation room. You can give a name to the clinic, plan a logo, and if you have a busy OP, you can plan a fixed day. You ask all the myopic patients to come on a separate day, so that counseling part you can give together. And you have to fix up to what age you are seeing the patient in the myopia clinic, and what will be the exit age for them, and whether you want to give it as a full myopia service or as a limited option. When you are giving it as a separate clinic or a room, the importance is the patient awareness will be better, and even your colleagues, it will be treated as a separate entity. So there should be a clinical board which should be highlighted. So seeing the clinic's name, even the patients who come for cataract and all, their grandchildren might be having myopia, they will be aware about it, and patient education material should be displayed well. And refraction, biometry, counseling, the parents as well as the children, everything will be done in the same room. That will help in the time management also. So now coming to the workflow in the myopia clinic. First part is identifying the patient. Then you enroll them in the myopia clinic, profiling, myopia workup, the recommendation, and then from the recommendation part, they will again go to the counseling. From there, either will go to the glass, drops, or myopia contact lens clinic, whichever is suited for the patient. So who are the patients who should be enrolled in the myopia clinic? All myopes after cycloplegic refraction. You can label them as myopia only after a cycloplegic refraction, because we are seeing a lot of pseudomyopes also nowadays. All those are already wearing glasses are a non-myope. They can also go directly to the myopia clinic. Pre-myopes or those who have a risk for myopia, that is when they have a less than 0.5 refraction, and children of myopic parents. Now you enroll them in the clinic, you have to keep a register for that so that you can get the details regarding that patients, and it will be recordable. You can also keep a WhatsApp support group if you want, so that if they have any queries or things, they can interact among themselves also. Now we just give a set of questionnaires to the parents regarding the age and history of ocular complaints, whether history of prematurity, developmental milestones, systemic conditions if any, drug allergy, family history of refractive error of the parents, siblings, amount of myopia they have, age of onset of refractive error for the parents or siblings. Now the questionnaire regarding the visual environment, that is amount of time spent outdoors, amount of near work, type of near activities, digital screen duration, type of digital screen use, lighting condition at school and home, and if they are already using glasses, age of onset, first prescription, present glass power, the duration of the present glass, history of progression, that is the frequency of change of glass, or previous myopia control treatment if they are taking, whether they are compliant with the drops or the glasses they are wearing. All this will help you in evaluating the patient whether they have chance for progression, as well as what are the recommendations that we should be giving to them. So must do thing are the basic evaluation like the visual acuity, IOP, slit lamp, and cycloplegic refraction. Dilated fundus is also compulsory, binocular vision assessment, and PMT in needed cases. Axial length and keratometry is also a must nowadays, because you will get an evidence for the axial length prolongation if you are checking the axial length. If the axial length is normal and if there is a progression, you have to rethink whether it's a part of pseudomyopia also, because whatever the myopia control measures we are looking at is mainly effective in controlling the axial length progression. So other things that are doing a peripheral refraction, if an open field autorefractor is not available also, you can ask the patient to look in the 20 degrees sideways and check the periphery. You see whether it is a hyperopic thing. That also will helpful in dispensing peripheral hyperopic defocus glasses. MEM retinoscopy, the MEM retinoscope can be used to find out whether the patient is having a lead or lag of accommodation. NPA, NPC accommodation facility, corneal topography in indicated cases, and tear film assessment. All these you can have a judgment regarding whether you need for that patient or not. Other tests include the pupillometry, especially if you are planning for a low dose atropine, serum vitamin D level because it has an association with myopia, aberrometry to find out the higher order aberrations, and macular OCT also in indicated cases. The following new myometers are now available. It has become, many companies are giving up new myometers. Myopia Master, which measures refraction, axial length, K reading. It do the data analysis, risk identification, generate reports. So it will give us a visual aid for the parents. So if you show them how the myopia is going to progress, it also track the axial length growth also. The OBM 12 measures 12 parameters in addition to axial length, AC depth, lens thickness, CCT, K value, white width pressure, white wide distance, pupil diameter, corneal diameter, vitreous depth, aqueous depth, and diameter of cornea. So MAIA also detection and quantification of myopic ocular growth, which also assess the risk of myopia progression. Fundus evaluation is a must in all cases of myopes. As you can see, peripheral degenerations and documentation is also very important nowadays. So if there is, all these children may have peripheral retinal degenerations. So fundus evaluation and documentation is also very important. Coming after, once you have the diagnosis from the myopia clinic, they come back to you. So you assess discuss with the parents regarding the condition, the progression, how is the myopia status, and evaluate the risk for progression like early age, increased screen time, low outdoor time, and strong family history. They are always have a risk of high progression. And what are the lifestyle changes needed? That has to be explained in detail to the parents. Risk factor identification, as Dr. Anla has told, various myopia calculators are available. They will give you an idea. You can easily access in the Google. The BHBI myopia, if you give the age and the dioptric power, they will give you a graph that what will be the expected myopic change when the child is at 17 years. If you are using a low dose atropine, what will be the myopic progression likelihood? That you can show that to the parents and counsel them regarding it. You create a myopia control plan in discussion with the parents and select the preferred treatment for the child. You discuss about the cost, effectiveness, and side effects of each. It can be either be glass, contact lens, low dose atropine, orthocare, or myopia control glasses, depending upon each child's need. Counseling, detailed counseling regarding the lifestyle modification, reducing the screen time, outdoor activities, and balanced diet. Everything has to be told in detail to the bystanders and children. So if a new patient is coming to the myopia clinic, you do a basic evaluation, cycloplegic refraction fundus in the first visit. And when they're coming for PMT, you can give them the questionnaire, axial length myopia workup, and give the final recommendation. If it is a follow-up patient, they can go directly to the myopia clinic and do the basic evaluation, axial length, and see how the compliance of the already given treatment, whether the lifestyle modification they are adhering to strictly adhering to what we have told them, and the myopia control measures, whether they are following up, and you can rechange it or continue with the same control measure as per how they are doing. And follow-up regarding the follow-up schedule, they have to be counseled regarding the strict follow-up schedule also. If you are planning low dose atropine, I usually call them back after 1 month to see how they are using it and whether they have any difficulty, how much is the pupillary dilatation, whether they are complying with it. And contact lenses accordingly you can give. If there is a rapid progression, you call them usually after 3 months. And if they are regular normal follow-up with spectacles, you do 6 monthly follow-up, and a comprehensive checkup is to be done annually. So from the myopia clinic, the patient will go either to the pharmacy, opticals and contact lens clinic. As like how to ensure the proper working, hold regular meeting with the team members. Team members include ophthalmologists, optometrists, and counselors if needed. And give them training, and whenever new changes happen, you call them in a monthly or 2 monthly base and give them proper training, how they are doing. Ensure proper documentation by verifying the records. You can give patient educational videos, and continuous monitoring is also needed. How will you add on to the clinic? You can do a school screening by which you can increase the number of patients, and kids of LASIK patients also you can screen them. All siblings of myop you can do an early screening so that you will have an early detection. Thank you.
Thank you, Reshmi ma'am. I now invite Dr. Leila Mohan ma'am for the keynote address about tackling myopia progression, choosing the right tools for the right patient. Ma'am needs no introduction as she is a senior pediatric ophthalmologist from Comtrust Eye Hospital, Calicut. She is a well-known national and international faculty in pediatric ophthalmology. Thank you, ma'am. Over to you.
Thank you, Dr. Anila, for that introduction, and thank you for this opportunity. Actually, Dr. Reshmi has given a very comprehensive note of how to go about myopia. So I'm just touching upon choosing the right tools for the right patient. Often we have some universal policies like environment management, and low dose atropine is not specific to some patient, but there are some conditions where we would prefer one to the other. So from passive optical correction to the active preventive measures to prevent the onset and the progression of axial elongation and myopia. So other than just a refraction, genetics, ethnicity, time spent outdoors, near work activities, accommodation and binocular status, all these have to be taken into consideration. And we know that Indians have less progression compared to the East Asian ethnicity. And NIM study has shown that we don't have so much of a progression as in the East Asian and Asian countries. So parental myopia is a risk factor, single parent having twofold and both parents having a threefold risk. So that has to be kept in mind when we are managing these patients. Younger age of onset, they also have a greater progression. So some common environmental factors like time spent outdoors, we already know from all these studies, Singapore myopia study, CLEAR, the collaborative longitudinal ethnicity study, all these have shown that luminescence of more than 1000 lux is protective for protection, which is given only in outdoors. Outdoor luminance is about 10,000 lux compared to indoor, which is 150 to 200 maybe. So reduced time on near tasks, early exposure to high near tasks, especially within 25 centimeters, is a factor for progression. And it is all the more risky in mesopic conditions when they do their work in the night, in low light. So meta-analysis have shown that there is 80% more chance of progression in continuous near work. So taking a break every 30 minutes is good for these children. And COVID pandemic also has shown us that digital gadgets have they have increased the progression. So contrast management is another field now. High retinal contrast overstimulates retina to overgrowth and myopia. And so there are some lenses which show some contrast management strategy also. So there are some guidelines. The impact guideline, myopia management guideline, put forth by the Indian Myopia Awareness and Research Group in 2022, and it was published in 2023. We know that no one size fits all, and there are no universal consensus, especially for ethnicity. We have to consider Indian context as well. So these are some of the 6-step guideline validated in 2022. Identify true axial myopia, whether it is axial or not. Mapping the risk factors, which she has already pointed out. Pick progressive myopia. Who are the progressive myopes or progressors? Appropriate treatment strategy. Consult, counsel, combine, and monitor regularly. And taper and cessation of treatment. These are the impact, the mnemonic impact with which we can follow. That's a guideline. So identifying true axial myopia, we know from basic examination with cycloplegic refraction, biometry, K reading and axial length. We do biometry for every patient. We do a biometry by optical biometry by IOL master. Rule out any corneal or lenticular pathology because those are not for treatment for preventing progression. Rule out pseudomyopia as already shown, and fundus examination. And mapping the risk factors. Document risk factors, a detailed history with a questionnaire given to them. We have already seen that early age of onset, they have to be seen more often, and stress the importance of progression. Lifestyle, of course, and how the pattern of lifestyle, whether the child goes out for outdoor activities, and excessive prolonged near work also, whether the child is stuck to the screen or the books. Accommodation lag, near esophoria, and peripheral refraction is if possible. All these have to be considered. So pick the progressives. So who needs myopia progression management? Increase in myopic refraction of more than 0.5 diopter in a year. That is a minimum at which we would start treatment is at least minus 0.75 or minus 1 diopter, not less. Or an increase in axial length of at least more than 1.1 millimeter. Our focus group recently, we had a meeting for low dose atropine management, when we would start, when we would stop. Recently, for 1 week back, AIOS along with the AIMS had a meeting in Delhi, and they had some criteria given for these. This is the criteria followed. The progression of 0.5 diopter myopia and 0.1 millimeter axial length. So unless you have two readings suggestive of progression, you can just send the patient for myopia clinic. She has already shown the counseling done in myopia clinic, how you would encourage the lifestyle, modify the lifestyle activities by exposure to sunlight, and just give her routine glasses. That's all we would do. So appropriate treatment in every case, every case of myopia is unique. Not all cases are treated similarly. So you have the pharmacological control, low dose atropine, or the optical measures, which are progressive additional lenses, PAL, peripheral focusing, defocusing lenses, or ortho K. Low dose atropine is one of the earliest and more widely accepted one. Though not FDA approved elsewhere, we in India have the liberty of using it. The CDSC has approval in India between 6 to 13 years, which is approved by the CDSC. So high accommodation lag and near esophoria, they benefit better by a progressive ad. Stress on the importance of special lenses, especially when you get a peripheral hyperopic defocus, and spectacle correction is more compliant. Some patients, the parents especially, they prefer spectacle correction to medicines, and start with a mono treatment, and affordability is a factor too. So pharmacological, as we know, low dose atropine has been proven. 57% of myopia control is there by ATOMS 2 study, and LDA has to be started if there is an increase in myopia, as we have seen, and maybe started earlier in school going children, or even earlier if the parents are myopic, where there is a progression, of course, and should be continued for at least 2 years, and then continue to teens if still there is a progression until stabilization is there. And if not responding, we can add another method or increase the dose of the atropine. Now 0.05 is also available. And a fast progressor or non-responder is considered as who progresses beyond minus 0.75 in a year. So, of course, we have talked a lot about the hyperopic defocus, which is the basis of optical control. And we know that this is the usual peripheral defocus this is an oblate shape of the eyeball, where even if routine concave lens is given, focusing is good at the fovea, but peripherally there is an hyperopic defocus, which we can correct by the myopic defocusing lenses or the spatial lenses. And this is our myopia clinic with an open field. We have an open field refractometer which gives the peripheral refraction as well. But other than that, we are trying to make 2 fixation points and see peripheral refraction by a routine method, so that we can make it more practical even if we don't have an open field refractometer, which is mostly the Grand Seco, this 5500, that is the commonly used one, which mostly a research tool, but it definitely gives an accommodation lag can be measured and peripheral refraction. So how we can go about it, whether to make it compulsorily mandatory for a peripheral refraction is a debatable point. But there are some custom-made peripheral refraction devices, not very expensive as this autorefractometer. And this is how you would do a 25-degree peripheral refraction can be made with a device like this. Or you can make a fixation target on your trial frame also. This is devised by Jitendra Jetani by fixing 2 targets when doing retinoscopy to do the peripheral. And this is the modern sort of topography. Multispectral refraction topography may be the future, because it gives retinoscopy at different areas. That is a newer addition to this. So in patients with hyperopic defocus, as shown with the peripheral refraction, these DIMS and all the myopic defocus lenses might be a better choice. Multifocal center distance control lenses are also available, and which is not very popular in India because of the risk for infection. We don't encourage that. It is approved, FDA approved in Western countries. So ortho-K lenses gives almost all 60% control, though it's not also very popular here. And it all depends on the choice of the child, the parent also. I'll just go through some of the cases. A boy of 12 who was being followed up regularly with low-dose atropine came after 15-month interval, and his refractive correction had suddenly increased from minus 3.5 to 5.25. With the cylinder was there even before, and the retinoscopy at center and nasal and temporal showed a difference of 1 diopter. And so we counseled him to have myopia control glasses, and we can convince them if we can do the peripheral refraction better. So this child became stabilized with, at least for a year, it was stabilized. So near work and lack of accommodation is another factor. Prolonged near work and reading with a lack of accommodation produces hyperopic defocus. This you can see when the child focuses for near, if accommodation is not there and it doesn't focus on the fovea, then again there is the hyperopic defocus even for near, and in these cases PAL or progressive additional lenses may be a better choice. It's a very simple, actually dynamic retinoscopy, MEM retinoscopy is not a very troublesome procedure. Just ask the child to look at where you are doing you can use the MEM cards, but even otherwise you can ask the patient to focus on your retinoscope with a target and do a retinoscopy. A normal is plus 0.75 to 1. And if it is more, then you can give an additional correction. Near esophoria is not very commonly seen, but if it is there, just do a cover test. If there is an esophoria, then you can definitely look for accommodative lag, and AC by A ratio can also be assessed. So this 10-year-old child with a minus 5 diopter had an increase of 1 diopter in a year, and the mother complained about her reading books with at close quarters. And we looked for near esophoria, it was not there, but MEM showed a lag of 1 diopter, and we gave her bifocals, and the next 2 6-monthly follow-ups, she was stabilized. So consult, counsel, combine and monitor very closely. All these have been already discussed, but monitoring is very, very important. Every 6 months, you have to bring them back and see whether there is a progression, especially so when there are the other risk factors like parental myopia. And then you may have to switch to another mode of preventing progression or increase the low dose atropine from 0.01 to 0.05. And tapering and cessation, it can be continued even up to teens, but minimum 2 years you have to continue with your strategy. And myopia control glasses can be used even to late teens. And tapering atropine by alternate days and then weekly, and slowly you have to stop to prevent rebound. And pre-myopia, as we have discussed over the past 2-3 days, I have been hearing that encourage outdoor activities and exposure to sunlight, and they need close monitoring. So lifestyle changes, encourage using TV instead of smartphone, pick up the progressors, evaluate binocular status as well, and myopia control strategy to be taken up whenever necessary and appropriately monitored. That is the most important thing. Thank you. I'm sorry, I took another.
Thank you, ma'am, for sharing the detailed and precise information about myopia management. And now I invite Dr. Amshi Filamasan, who is a senior pediatric ophthalmologist who is working in multiple hospitals like Aradhana, Precise, Gitanjali, and Shankar's Eye Hospital in Trivandrum, to speak about monitoring and adjusting myopia therapy.
Okay, so my talk will be a simple talk where I want to focus on mainly the general ophthalmologists, because I think they see more patients before they are referred to us. So let's go with, and many of the patients that come to me from general ophthalmologists, they've already been started on atropine by them. So I want to just give a short layout on when do we start and then how do we monitor, and then you can refer to us. That's another thing. Okay, so why do we need to monitor myopia progression? Because the rate of myopia progression in Indian children varies between 0.07 plus minus 0. Up to zero point 0.5 diopter per year. But younger children, like Laila Madam has mentioned, they progress faster as compared to the older ones. And so, because of rapid progression, we need to monitor them more closely. And then we all know that every diopter increase in myopia leads to increased chances of maculopathy, retinal detachment, cataract, and so we want to keep them on close monitor. As previously mentioned, there are different factors that come into play when it comes to the management strategies: lifestyle, optical, pharmacological, and the newer ones like red light therapy and upcoming emerging research like 7-methylxanthine. The current challenge for clinicians, including pediatric ophthalmologists and general ophthalmologists, is that there is no proper guideline as when we should initiate the treatment, how to initiate the treatment, and how to monitor this progression. So that's when what Madam has said, the impact myopia management came into being. First, we have identified the true axial myope. Then we map the risk factors as previously said by Madam. And we need to pick up. So only those patients who have progressive axial length elongation are eligible for myopia progression, as most of the therapy that we use, they are confined to this axial length elongation. And we need to advise appropriate myopia control strategy. And in our Indian scenario, counseling the patient and consulting them and monitoring them is very, very important, because no matter how many times we counsel, we still lose follow-up of them because they like to do doctor shopping. Eventually, most of them will come back, but if you know how to give the correct counseling, then they will always come back to you. They will go to 2-3 more doctors. The same 2-3 doctors will say the same thing, and then they'll be like, okay, that first doctor said the same thing, so they'll come back to us. So irrespective of whether it's pediatric ophthalmologist or general ophthalmologist. Then we have to know about the taper and cessation of the control. So the first step about true axial myope, it has become very important, and as previously discussed before, what Rashmi Madam said, every patient, every child that comes to you, irrespective of whether the child is myope or not, do a detailed history. You don't have to have a myopia clinic for that setup. You can, in your OPD, do the detailed history, take all these necessary things, and if you want to monitor the progression, we strictly follow by this, where we measure axial length at first visits to have a baseline of how it's going to progress. And it's better to take keratometry baseline also. Then, as usual, we give glasses and follow up. For me, I would like to follow up at 3 months, then at 6 months. So this is a type of format that I have started to keep. So every child that comes, we have a small chart where there will be axial length is written and the month they visit. So the problem with our scenario is, even if we call them at 6 months, they will not come at 6 months. They will come whenever they want to come. So preferably, if they come correctly at 6 months, the monitoring would be much more easier. If not, then we can say like August, or whenever they come, make a note of the axial length. And you don't need to, okay. The other thing is, the step 2 is we need to map the risk factors as previously said. If the parents are myopic, early onset of myopia, if they have less outdoor activities, and if all the tests that has been previously mentioned, we map those risk factors. And then on the subsequent follow-up, if they start showing increase in axial length, then we pick those progressive myope and we follow up how much it's progressing. So around 0.1 millimeter progression is, yes, acceptable yearly. But if it is more than that, then we have to go for myopia control. So what to do if there is no axial length increase, but the power has increased? So we, like Madam said, we have to look for something like, is it lenticular cause? or is it curvatural cause, or is it pseudomyopia? Okay. Then this is where it comes into play. So axial length, it's good to do lens thickness also, which will help us to know about the lenticular component, and white to white measurements. And this may not be available in every clinic. So what you can do is axial length, if you have a B scan, you can, most of the people who will be doing cataract surgery, if you have a B scan, do the B scan, you can manually measure it. Okay. White to white, you can manually measure it. If you can, in slit lamp itself, you can measure. There are several instruments that have now come into play for myopia monitoring, but all of these instruments are very expensive, and I don't think many of us can afford to have that in our clinic. So like I said, basic axial length you can do with B-scan machine that you're using, and keratometry you can do with your AR machine. Then appropriate treatment strategy, the fourth step would be, if there is a myope with relative peripheral hyperopia, then we'll go for defocus glasses or multifocal soft contact lenses or ortho-K lenses. So in Indian scenario, like Laila madam has said, we don't prefer contact lenses because we don't know how hygienic the parents are handling the kids, how they're going to put or how they're storing it. So preferably we'll go for the defocus spectacles. Then we have those individuals with high accommodative lag or esophoria for near viewing, preferred for bifocals or EDOF contact lenses. Among the low dose atropine, 0.01% is the most studied, and Laila madam has described in detail about the various studies. So the exact mechanism is not known, and that's why the FDA approval is still pending, but in Indian we have started using it. I'm using it in a couple of my patients, and so far I've had good results with my patients, and few of the patients have stopped the medications by themselves and lost follow-up and come back again. Luckily, I haven't seen any rebound in them. Basically, it acts by suppressing the axial elongation. We use it at night time, and they say that once, if a OD dose at night is not sufficient, you can increase it to BD, or you can shift on to 0.05 OD dose. Adverse effects I haven't seen in many of the kids, and preferably it would be better if you do pupil examination, pupil size measurements to see what is the effect of the atropine. Myopia control lenses, there are different type of lenses. So depending upon the companies, the technology varies, but basically, like it has been previously said, the central area would be the one that is clear zone of central area, surrounded by a zone where there will be a which will cause some peripheral defocus, and that will cause this one, myopic defocus. So several studies have been done based on them. This is just to show you that yes, even though the lenses are expensive, if you can prescribe them to your patients because they are reliable, and all the studies have shown that they are better than single vision lenses. Ortho-K lenses, they causes a flat central curvature, so that it causes a compressive positive pressure centrally. It causes flattening of the central part of the cornea, and it is worn at night time. The benefit is that they don't have to wear glasses throughout during the daytime. But there are several contraindications, like madam said, infections. And the advantage is that it's reversible. So the moment you stop using the lenses, after 10 to 14 days, it goes back to the normal corneal contour. So coming to this, we always start with monotherapy. We don't start as combination in the first go. Monotherapy, you can decide whether you want to go with this one, atropine 0.01%, or whether you want to start myopic defocus lenses. So then we come to consult, combine, and monitor closely. So there's a small flow chart which will help you to just approximately have an idea how to follow up. So once we start anti-myopia therapy, the first follow-up is preferably as first month, where we follow for the side effects or any adverse effects. If we're using atropine, we want to see if there's any pupillar dilatation or if the child has developed any skin allergy. If it's ortho-K, we want to see same thing, any chances of infection or not. And for all this monotherapy, after that we follow up after 6 months. So at 6 months, a good response would be said if it is less than 0.2 diopter or less than 0.1 millimeter increase in axial length in 1 year is said as a good response. If it is more than that, then we have to think about combination therapy. If it is a good response, we can continue with whatever treatment we're doing, whether it's atropine or Toke or defocus spectacles. So when do we start thinking about combining these therapies? If it's a poor or non-responders to treatment in 1 year, then we can reassess and think of combination. The advantage of combining more than one therapy is that it has enhanced efficacy and it has a synergistic effect. The disadvantage is that, especially in Indian scenario, the cost increases drastically, and so the patients become little bit reluctant. But also there is a side of increased side effects. So several studies starting from 2019, they have tried combining multiple eye drops along with ortho-K lenses, atropine 0.1% with soft contact lenses and myopic defocus glasses. And some of them have found to be effective, some of them have not worked. So mainly now, whether it is monotherapy or combined therapy, we always have to counsel them for lifestyle modification, where we have to make them to increase the time they spend outdoor, preferably 2 hours in a day, and maintain postures, take frequent breaks in between studies or when they're using gadgets, because all the studies that have been done to study the influence of my environment and lifestyle myopia has shown that this helps to prevent onset of myopia and also prevent the progression of myopia. Also, there is a dose-response relationship. So the more time they spend outdoor, the less progression they have. So whenever we start any treatment, we have to know about when to stop it. So preferably, like Laila Madam has said, we have to stop it after 2 years of stability or once they reach adulthood, that is at beyond 17 years of age. However, it has been seen that in few individuals, because myopia progression has been noted in few individuals, even in early adulthood. So like previously said, there are some apps that we can use which will help us to demonstrate, or to the parents, we can explain to the parents about myopia progression. This app is called bhvi.org. We can go enter the ethnicity, the age of the patient, the gender of the patient, what refractive error they have, and how all these different types of treatment is going to affect the myopia progression. So they will. So let's say I select 0.5 to 1% atropine, and then it will show a chart like if the child was not using that eye drop, there was chance of 3.3 mm progression at the age of 17 years. If the child is using these eye drops, it would be managed, is expected to elongate by only 0.38%. So these are all AI based, and they don't give a exact value, but they will have an estimate, and it is more easier for us to convince the parents about how we can monitor the progression of myopia. So basically, like previously discussed by all the speakers, no matter what we do, there is nothing called one single treatment for one child. It has to be modified according to each child's need. And close follow-up is very, very important, because that's what's all about. That's what everything is about, right? Like we want to know how it progresses. These are my references, and thank you.
Madam, I have a question for you. When we are starting on a myopia control glass, till what age we ask them to continue them with the same? Or when we can shift them to a normal single vision glass?
We have found that myopia in at least in few adults, it goes into adulthood. So glasses, there is no harm in using it so long as he's a progressor. Even it goes up to 20, 21, 22 also. There is no harm. Not that I have seen, but I have discussed with some of my peers. So I have heard that very occasionally they complain about some shadow, but it is not consistent. Once they get used to it, it is not a consistent problem.
have a stable refraction, from what age we can shift them to a normal lens?
After 2 to 3 years of using glasses, if it is stable, and especially after he is 15 to 16 years, that is the age of progression, you can think about stopping that. But what I have seen, I don't know, many of my patients, they ask for, they have come from abroad, they would like to continue when they see that there is no progression. So
Our patients have a little problem with the cost actually.
yeah, cost factor is definitely there, and in our part, actually, there is a in Malabar, at least in among girls, they don't want to use glasses. So in that way, probably low dose atropine is a preferred mode of management. But definitely, if you start, especially because this optical correction has been in market only since few years, we don't know the long term outcome, but we can definitely go for the high, low, upper teens, definitely.
And now we have this 0.05% atropine, ma'am. What's your experience?
I have not yet used them regularly, but I know a lot of people start off with 0.05 also. But we had a recent discussion how to use low dose atropine. National guidelines they are making, All India Ophthalmic Society. So that is not the first line of management, definitely. Go for low dose atropine 0.01, and then only among progressors you go switch to 0.05. It has been marketed only very recently, and I have not used it.
I have used in 2 patients, but only 1 month follow-up I have. They have a pupillary dilatation little more than 0.01%, but they don't have any reading difficulty. But
That's
long
the
term, yeah, but long
yeah.
term we have
But main, I 0.01, I have just had among 300 patients, I have just had one who complained of photophobia. But 0.05, that is another, maybe more, little more.
Thank you, ma'am.
I really thought only chairs and tables will be there, but thank you. Laila ma'am and Rashmi ma'am told me that don't worry, only tables and chairs will be there, but it is different. Thank you. Thank you for coming.
Special thanks to our recruits, Anita madam. Hi, thank you for coming, Anjana. And then, what's her name? What's your name again? I forgot. Alka, yes, yes. All my supporters.